very, this is true a chip case. Chip in the sense, not only complex intervention, this also has a valve disease, and that is more and more cases are coming to our life now because patients are living longer, aortic disease, and this actually, I know this is your case number 9, and if you, yeah, so an 85-year-old patient who presented few days ago with a dyspnea and chest pressure, negative troponin, slightly high BNP. He has few other risk factors, and basically has a progressive aortic stenosis, which will show you the gradient and so, and has a 2-vessel and left main bifurcation. Question is what to do with this patient. Young person probably will go for surgical valve replacement, high syntax score, but this because of the age, the plan was to just do a rotational atherectomy and maybe the provisional stent approach. By guidelines, it will be not appropriate, but after the heart team discussion, these cases are appropriate. With that note, Anu, tell us quickly, what are you doing?
This is where we are. We did, this is
you went there.
Our way of doing, we just do a aogram, but that is just, we use AR2. We always like to use AR2.
What do you mean? Huh? No, it's fine. Yeah, continue. Yeah.
And then
we show the gradient. Hemodynamics, please.
Hold on. This is how we cross the aortic valve is just using a Terumo, straight Terumo wire. And this is where we are with the, in the LV, you can see the gradient now.
It's a 45 plus gradient, and the key is, the case basically, just 1 second. So let's go to the angio, particularly it's a 10 French sheets. We put a 2, no, we did the left system. 1 second, off fluoro. 1 second,
I don't
off
have
fluoro. Okay, here. This is the left main disease. Look at that. Subtotal LAD, multiple lesions, kind of a left dominant system with lot of disease, which you can see here. We'll come to that. Okay. Well, quickly, because of high gradient, usually we don't do the, and actually we can have a discussion by the faculty that do you do a tower and PCI together, or we do a BAV and complex PCI? We try to say, in United States, we try to avoid doing both together for various financial reasons, and so we do a BAV, PCI, and bring the patient back if the high gradient. Otherwise, just do the PCI pre or post tower. Yes. Okay. So any question about it? Because of, as I said, peak velocity is 4.5, and so can the tower be done? I mean, could be, but this kind of complex, you saw the subtotal left mains, and so coronary is a more preference, and we dissociate them. I know many trials they actually had done the the tower at the same time.
Yeah. There's a small study published in Euro Intervention also that compared PCA before TAVR simultaneous or PCA after TAVR, that clearly showed more events when we do PCA and TAVR together.
Yeah, absolutely. Why we go with the JR only? I mean, implant. What happened?
No, we did. We had to change always to pigtail before we put this.
Okay. So
stuck.
yeah,
Okay,
good,
now.
Very good. So now which we have put now confida wire. We are going to use now a 20 millimeter balloon. Again, don't be too aggressive, and just get a 20 millimeter balloon, and we have the guide ready for the left system. Now only question is, at age of 86, patient who is a AFib will require antiplatelet therapy. If we can come out with a single stent at the bifurcation level, we'll prefer. And we are going in now with a 20 millimeter ZMAT 2.
Can I?
Yep.
Yeah, but with a 40 millimeter peak gradient, and such a tight left main bifurcation, would you really want to do the BAV, or just go ahead and straight just do the LM bifurcation and come back and do the...
That's BAV a very good point. Yeah. Believe me, with this we started the policy long time ago, and if there is a severe gradient, we saw that even during PCI they get into more trouble. And just because of that region, we have tried, and we now actually have multiple cases of this combination. Now, we either do nothing or just go to 180 quickly,
no,
or 150. 150.
Wait.
No, why the groin is not connected? Pressure. Where? Just 1 second. Pressure. 1 second. Don't go yet anywhere. Yeah, so because of that, yeah. But the point is well taken. That do you want to just go PCI? But remember, these patients may get very unstable also. Flash. Yeah.
It's okay.
Okay, go. Yeah, go.
Yeah, because some
Yeah,
of these patients do not
go.
tolerate pacing at
Low, but yeah, negative.
high
And
Advance,
many,
doses.
advance.
yeah, go quickly. Yeah, and don't do pacing.
Stop. Yes,
Yeah,
holding this.
yeah, go. Sorry, 1 second.
There is
Yeah, go.
a
Go.
severe AR, then
Yeah,
you would
no,
have to go
negative.
into
Negative.
heavy now.
Good,
Yes.
good, good.
That also is a
Fine.
problem,
Yeah.
additional problem.
No, but that's a very good point. But remember, we're trying to do undersize and not over uh, the off pacemaker. Now we need to give some medicine. Pressure is a little low, but pressure was low to begin with. Now this is only thing is you go very negative for this to come out. Good. All right, ready for real. The second part of the chip. Valvuloplasty has been done. You want to check it, but we can check with a guide catheter. Once we do, we are not going to do anything further. Yeah.
Is the patient on some supports?
No. So question is that now, do we put our impella? So some cases we are done with the
Yeah.
impella assistance.
Hold on.
Uh,
It's crashing.
Huh?
Let's have the trick tail.
Okay, increase some neo
Somebody
injection.
has to mute. There are phone calls and other things that we are hearing. You have a
Sorry,
little bit of epi.
sorry, ma'am, for you to
Yeah.
get such a tough case on a Saturday morning. We are feeling for you sitting here.
Yeah. Give some atropine also, may take it.
Yeah, yeah.
Yeah.
Give-
So we
give-
just
give
want
a
to
little
adjust some hemodynamics first.
Give us, you know what?
We can
Let's
take
try
it
to-
out.
Yeah, 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 I know, but I need a pigtail to remove it.
Pigtail? Okay. You want to give undiluted or give 0.1 of happy?
Go. Get us the.
What?
I think pressures are going a bit low now.
Yeah. There is
Okay,
patient
give a, what are you giving?
Paste.
Neo? You want to do a quick aogram?
yeah. 1 cc of epi. Yeah.
He's talking.
Give
Guys,
atropine
can you mute the phone?
and take the
Somebody,
pacemaker.
we can keep hearing some phone call that's ringing.
Now we can give atropine there because I think the low pace also help against us.
Okay, good. Do.
1 second. Yeah,
No,
it's coming up a little bit. Yeah,
Coming up, it's coming up.
yeah. No, the looks like patient is pacemaker dependent. When did it become dependent? Before?
No.
His rates were quite low from the beginning.
Yeah. So the native. Yeah. So right now it's good, and we want to make sure that there is no severe AI, which it is not. Remember, hemodynamics doesn't say it.
Yeah. Distal is
Diastolic is good.
Yeah. Good. All right. We are ready for the real second part of the chip. Yeah. Too much. Now we overshot. Only 1 cc. Huh? Okay, we'll slow down here. Now we are going with the VL 3.5. The guide catheter.
Could you show us the angio, Dr. Sharma, sir?
Yeah,
so that
yeah. We'll show it again. Yeah. It's a bifurcation, distal bifurcation with a subtotal LED. While we are getting ready, no, but you want to give some verapamil or something?
No.
Way too high
go,
pressure.
It's okay, it will go
It's
down.
called hemorrhage.
No, it will go down. Don't worry. It'll go
Yeah.
down slowly.
Let's talk about there. We are ready with the rota here, 1.5.
No, yeah, I think do
One
just
second.
balloon and come out.
No. Rota has to be done very calcified. No, 1 second. First thing, blood pressure 240. It's
It
going to
will go
bleed in the
down.
brain.
Maybe too much inotrope has gone in.
No, just once. What happened is Neo did not work. So we gave 1 cc of epi, and I told them anytime when you have a total issue, give 1 cc. So I think 1 cc was a little too much. Should be only 0.5. You want to give a little beta blocker, or what do you want to give?
No. It will just settle by itself.
Okay,
Maybe
let's,
just 5
We just have to wait.
yeah, yeah.
Everybody need to take a deep breath right now. Okay, it will just settle by itself. Otherwise, we are doing this yo-yo, hypertension, 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 hypertension. That itself is not good.
Yeah, it's coming down, yeah.
Yeah,
Yeah.
good, good. Don't give any more. Yeah. Now, before we proceed, I keep hearing the phone ringing. Anybody
Yeah.
is hearing it? We will
I
not be
also
able
hear
to do
it.
the
Someone-
procedure.
It's not from the
Not from the
hall.
hall, ma'am.
Huh?
It's not from here. The phone is not from here.
Tell our audiovisual people, make sure they are not having the phone on their side.
There is no phone from our side.
No
Okay.
phone in the hall.
Okay.
What happened with him?
Things are
He
quite
disappeared?
good now.
Huh?
So it's a Medina.
Can you talk to your audiovisual people?
Yeah.
No, it is. They tell the guy from India. Maybe their room there.
Okay, it's
very
a mud.
disturbing.
One by one. Okay. Now, are we ready with the fielder, fine cross, and rota 1.5 bar? I actually forgot to introduce with this excitement myself, Dr. Kini. We are two fellows, Manish Vinayak and Gaura Aurora, and nurses are as usual our the live relay, both Will and Ashley and CVT, Asif and Hakeem. Usually we have.
Trust
yeah.
me, there is no landline here from us.
Okay.
No,
Mostly,
what I meant is your
control.
AV people who are in the room. Somewhere in the room, they're sitting there.
1.5 bar. We are hearing the noise. Yeah. Okay. Let's go. Now still pressure is high. Why? Why going up now?
Okay, let's finish the case.
Okay.
His LV has recovered, I think, Nakshama.
Yeah. Maybe. Yeah. Maybe part of that is
No,
also.
please,
Go.
let's-
Yeah. See. So where is this noise then? 1 second. Go.
Right.
Keep going.
We are very sorry for this, but ma'am, there is no phone in the room.
No, but
Okay, I'm telling you very
But
simple.
are you hearing? No,
that
no, one by one.
audiovisual people
also
who are
hearing,
sitting.
yeah,
Yeah.
you are hearing too. Huh.
Figure out from your audiovisual people.
Somebody on the Zoom, maybe. So mute the Zoom. Very simple. That happens many times. Good. Mute the Zoom. All right. So now we attract our attention to the complexity of the case. And as you can see, we are all good. Okay. Now this is the kind of case you need to go with a fielder fine cross and go to the LED. See that LED is a tough one and critical one for this patient. And we are ready for and very calcific. I know IVUS can be done to decide or any other technique, but we'll try to do it. Let's go. Just do it without it, and then question comes that how we are going to do with the two-stent
175.
approach.
Should have been 175.
Slow flow. That's okay. If need to be, we can use the IVL ready. Also 3.5 if needed.
You're not
Plan
even
is
that. There's
wire imaging or wire
Say what?
rotablation.
dent. I mean,
That's
kink
okay.
in
Will
the.
be okay. Will be, yeah. So no, no. I think this is because of the subtotal nature. We try to do because little die.
So ma'am, it's a focal lesion. Will you use a 175 or a 1.5?
Yeah. So very good point. We actually ourselves having a discussion. We decided 175, but once you have a TIMI2 flow, you saw that LED has a TIMI2 flow.
You're I think yes, I would have gone with 175. It's a very short
So go.
segment.
175 will take 1 minute.
No, but a 1.5 is open. Let's use it. One thing against it is the LED takeoff.
Yeah.
Yeah. So we'll, now it's they already opened one file. Let's just use it.
Yeah, there is not
Does
enough.
the guide have a kink over there?
Yes,
Yeah,
we
we
know
saw that.
We've seen that. So the risk of having kink. Can you just change the curve then?
Mm-hmm. Let's go fluoro 1 second. Little die.
No, you're not. The one is that the rotopper can get stuck there. Stents will get stuck there.
We'll do a guidoplasty also. They'll die.
Maybe after the rota, we can put a guide extension beyond the kink, then nothing will get
No,
stuck.
no, no. We'll
No,
do a
no, no,
balloon.
we don't
Balloon.
need that.
Remember, as I said, there is a further lesion. We are not going after with that.
No, yeah, you will have to take care of that lesion. It's
No, no, but after
95%.
rota.
No, no, advance the wire.
Okay. All right. Good. Advance this then. Go.
Fine
Okay.
cross.
1 second. Yeah. It's a fine cross. So that we thought that this case is not a rota case directly. Good. Advance. Advance. Good. With rota.
Get us a new fielder wire.
Okay. Yeah.
Is it a regular rota wire or rota
Yeah.
drive? Dr. Sharma?
Rota flop.
Rotor flop, yeah. Yeah. The other rotor, all are the rotor drive now. Even in India also now, right? I know rotor legacy, old one is still there, but here in whole America and I think rest of the globe, that all has changed completely now. Everything is Rota Pro. And we are working on the second part of the rota that burr get stuck many times. Then what can you do? Coat the burr on both ends. So we did some data, some experiment, and we are making some changes. Good. We have to go to this view was your
Okay, can you give me some dye? I
LO23.
don't even know distally how the LED looks.
Where is the wire now?
Okay, let's leave it there. It's in the LED.
Okay.
Okay, now we are in the apex.
Good. Okay. One second.
Dr. Sharma, we always used to use a long sheath. We have not used a long sheath in this case. Any particular reason?
Yeah, 10
Because
French.
it was a 10 French.
Yeah.
It is still a long, not 45, 46 centimeter, but 20. So it is long.
Yeah, but yeah, not the usual one. In this particular case, just because the 10 French, we don't have the 10 French. We have some long 10 French we will try to avoid, but could be yes. And this is a case actually, if you need any time, we have the impeller in the room. Some cases we are done. This complex case, balloon valvuloplasty, then impeller assisted PCI. We have now 28 cases. I think the review of our cases of last 3 years, 28 cases of this kind is we have fellow has prepared and very safe strategy. Idea there is just the moderate BAV. You're not going for the finish line because we know that that's not the issue here. So that basically is the region. As I said, 18 millimeter you use, 18 or 20. Women we use 18, men 20, and just dilatation, not that over with a syringe, and that's what we are able to do here. Okay. Now we are ready with the 1.5, and if yes, that is true, it should be 1.75 because of the short burr, short lesion, but in this particular case we selected because of the TIMI 2 flow. Okay, let's check it. Go.
What is the
Good.
anticipated strategy, Dr. Sharma? Is there
Yeah,
any,
so very interesting.
irregular or-
Yeah.
No.
So this case, with this age, we just going with the Plavix. Remember, a lot of data now that patient with the old. One second. They cannot see the wire clearly. Is the light down? Yeah. Okay. Good. Yeah. Can we do a little light down? Yeah. Good. But that's it. Yeah. Yeah. So in this case, the long term, and now he could not tolerate any NOACs. So he's on Warfarin for his AFib. So this one will be the case of clopidogrel and the Warfarin. And he got the.
Did we check,
Yeah.
Did we check the speed outside normally? That
Yeah, we did. We did already. Yes, we did
No,
already.
With
One
the Rota Pro, it is the speed of 150 is fixed. So we do not check it like we used to do it in the legacy anymore.
Yeah, but we did. We did. Always you have to check outside. The machine is working. What if the machine has some technical fault? We know that unfortunately, what happened even in the best of the best planes, things can happen. So we always check it first. So these are 3 steps: moving forward, backward, and one on the Dynaglide, and it's ready now.
So one question, Dr. Sharma.
Yeah.
Patient is on Warfarin and
Yeah.
he's on clopidogrel.
Yeah.
So did you bridge with Clexane or you
No.
continued with Warfarin?
No, but he was admitted 3 days ago. and we stopped it. At that time, INR was 3.8.
Can you move this?
Yesterday, INR was 2.4 or 2.2, and then we did the Cath, and the patient is ready here for PCI. So in this case, post-procedure, we'll give him clopidogrel loading dose was given, and then he, if necessary, we can give him heparin, but we try to avoid it. Yeah.
Okay.
Yeah, but you are right. I don't think there is any role of those. If you really need, you can give the Cangrelor, which will be soon available. I think Cangrelor are available in India now, right?
Yeah, it's available for last 2 years, Dr.
Yeah, good. So this is the good case for Cangrelor. You want to take it to the mid LAD also in epicrania? It's a 1.5 bar. Yeah, patient tolerating so far so good. And we'll go to the mid LAD lesion or distal LAD lesion now.
Also in this elderly patient, when they are doing complex PCI, do not give any strong antiplatelet therapy until you know your procedure is safe.
Yeah.
Because one of the deadly complication is wire perforation.
Yeah, Sine. So we know that how far the lesion is.
Yeah, so you go one
Yep.
second.
Let's take us one picture. So we have to go that far. Very complex.
Okay, so we can show you how we can use DynaGlide and move forward. So you get the Dyna button. You see this knob. This is about 9 centimeters. So you need that length to go there. So you tighten the knob. Okay.
Yeah.
And then what you're going to do is your brake release. You press brake release right now.
Yeah, they're
You can
seeing
see
it. Yeah, good. Brake
you see
release
the
and
brake
sheath
release
yeah.
and hold the wire.
Yeah.
When you do brake release, it's free, the wire. And now press the Dyna. Yes.
And that's good enough.
No, I think it's not going. Come
Yeah, that's
closer,
good.
Okay.
Yeah, okay. We can stop now. Get a 2.520 high pressure balloon also. Now we are ready. This will give you enough 90 centimeter. Yeah. So we actually see a heavily calcified lesion, that LED also very further down. Yeah, good. Beautiful. Yeah, 20-second runs.
You want? Okay. Start coming back. Let the run through wire.
Run through and fielder both. Yeah.
You want
Go
to
back.
upgrade it to 1.75 for the proximal alone, or you want to go with balloon for?
Yeah, very good point. Very good point, actually. What if, let's prepare the distal LAD lesion first quickly, balloon stent, because that was also 95% lesion, and stent there, and then proximally decide. I would just say now, and let's ask the other panels what they feel. To me, I think this is the case now. If need to be, just combine it with the tripsy or cutting balloon. Yeah. Right? I mean, ask the panelists what is people's opinion, or that upgrade it or combine the devices, because now getting the second burr, I would say, happens in maybe 2% of cases in our lab. We do 65 rota per month, maybe 2 cases, because the key is because those now everybody getting the IVL or cutting balloon. Yeah.
The way the 1.5 burr cross, sir, so maybe a 1.75 will be good. We have all been trained by you, so we think that probably we'll use a second burr.
Yeah,
It is more cost effective also in
Yeah,
comparison to
that is true.
IVL.
Absolutely. No question. People say in the calcific lesion, why can't you use more IVL? I say yes. If it's the same price or the balloon, we use it. Same here in America, balloon price is $200 and IVL is $4,500. Okay, let's say the stent strategy.
You put a.
Or you want to do
You
an
take a
imaging
proper
and see
picture.
the design?
That also we can do. Yes. There's a long lesion in the LAD, right? See that? So use a long 2.75, 32, 33.
No, I put a 2.5. I don't think it's a.
Okay, 2.5. Yeah.
Let's balloon and see.
Yeah.
It's diffuse disease distally.
So just do the focal.
Focal 12 millimeter.
Well, I don't know, 12.
What is this
It's 20.
size?
Is it 20? 2.520. There is
To
a
be
no.
fair, if
Yeah.
the patient is in India, most of us would have ballooned it and do a DCB for the distal lady,
Ah.
then that option is not there in US at present.
No, we have. Yeah. So only question is the cost issue.
Vessel?
Yeah, native bath. No, you can use it. You have it a little further down.
No.
Yeah.
That's good.
So question only is the price. The cutting balloon here, sorry, drug-coated balloon is 5,500. 5,500. Compared to there, it's barely like
wait. It's a bridge. Don't get crazy. Perforate.
Yeah.
It's a bridge, so you have to be very careful.
Okay.
Okay, down.
Yeah. So we have all the strategy. If you need to upgrade the bar, we can upgrade the bar.
Okay,
Also,
let
you
us
want to take a
see how
picture?
it looks. Yeah.
Okay.
Then decide.
Let me ask Dr. VVC Reddy and
Yeah.
Dr. Roni, how do you proceed further?
I think as Dr. Sharma is planning, a stent there distally first,
Yeah.
then prepare more of the proximal with probably a cutting balloon,
Yeah.
and then
That's what I
figure
was
out the
saying.
strategy.
Just do the shot there then.
No, bad
I
disease.
would, at this point, I think imaging would be warranted to decide what we should do with the proximal lesion.
Agreed.
Maybe
Yep.
I think balloon itself will do. We may not have to take another calcium modification device at all.
The Varapam
Okay,
will mix.
go.
Yeah.
We are deciding the length of the distal. See there?
Yeah.
Huh?
Yeah.
Right? You want to put a long one or
Just after the diagonal, let's put a 2.5. Huh?
12?
Is there bad dissection in the osteoproximal LAD?
No, it's the same tight lesion. We are not ballooned at all yet.
Yeah, the I was.
Yeah.
You want to put just short?
No,
Or
we
take
do this
care of the
balloon.
28. Okay,
Huh?
come. Huh?
2.528, right?
Yes.
Yeah.
Okay, come here. Let's dilate here. This is
Yeah.
28. May not cover it.
No, but then 33.
30. Yeah, 33.
Yeah, let's go 33.
2533. Okay, down. Zions.
Zions. Yeah.
Okay, good.
And then you have to open the ostium a little bit because Burr
No, it
did
doesn't
the
matter.
work.
It's 20 millimeter down.
33 is good or 38? Yeah,
Because
no,
below
ostium,
the
ostium.
diagonal,
38.
there is a long
Yeah,
lesion below
yeah,
the
yeah,
diagonal.
yeah.
So landing zone is way down.
Yeah, I mean, in this case, but using a 38
No.
also is not a big deal.
Okay.
It's not going to get any time, bypass surgery, even if there is
38 he wants.
restenosis.
2538.
Yeah, good. Okay. You want to remove the rotor after we deliver it, yeah. And then we do the imaging. Agreed with our all panelists and friends that after the taking care of the distal lesion, then we will go with the imaging to decide cutting balloon, IVL, and or upgrade the rotor bar. Only question, as I always say, we don't have any magic or AI algorithm to show that it's been cut, so that enough plaque modification has happened. Where some people say maybe if you see the 3 cracks or fracture in the plaque, calcium may be good enough, but I'm a little skeptical. So I think since we had no clear.
And when we do the imaging, sir, probably we can also image the circumflex because maybe we can leave it alone. It looks quite okay. Maybe in this.
Will be nothing wrong in that, believe me, if you leave the circuit. That's why I said, even if we plan, this usually we say 2 as double stent strategy, but not in this particular case. Because of the,
55 and on.
And not only that, he'll be require only single antiplatelet therapy. I mean, of course, and then of course we'll be on warfarin. So we can take the rotavirus out.
Some die.
The rotavirus out, yeah.
Wait. Some
Okay.
die.
Yeah, you have to pull back, no?
Oh,
They pull back.
okay.
Yeah.
Now we are good.
Okay. Going up.
No, wait. Okay.
Yeah.
Go up.
Okay. This is 16 atmosphere.
For LA appendage closure.
Down.
Yeah. So that's another point that do the LA appendage closure. And I know the data on the tower and 16. You want to go a little distal also or no? Little massage with the distal in this particular case. So clearly the watchtower did show has more embolic events by using. So it has not become very popular here, even in America. Good. That's it. There's 2 atmosphere. Yeah. Good. I'm going. Yeah. So the combination, but I think it's enough. Once you become a little more combined data, and big issue here, anytime you use more than one device, you are reimbursed only for one. Compared to India, that whatever is used, those who are the device use, reimbursement point of view, you add on to it. Here, it's only one DRG. So where you use a 1, 2 or...
Okay, take a picture.
Yeah,
I was ready.
yeah.
Oh,
Want to do massage more distally?
no, leave it.
Yeah.
It's
Okay.
bad disease. It's diffuse
Yeah,
disease
yeah.
up to the apex. I think we can leave it alone now.
Yeah. And we can remove the rota wire.
Now let's image, because as you guys are they're saying IVL versus
All right.
if you need bar, we already did 1.5 bar. I think then you got to go at least 0.5 higher.
So we can go up to 2.0.
2.0.
7 French will
7
take
French.
2.0.
We have to do our image interpretation ourselves. Kiski has taken a break and gone to Japan.
And I know that India is very big on imaging, as you probably saw our CCC live. Now we are doing imaging every other month. First Friday of every other month.
Okay.
Yeah, go to RAO a little bit.
RAO, no? Straight RAO.
Good.
Who is there? Asif? Okay. Go live. Let us see. Okay, that's a left main.
Mm-hmm. No, distal left main is definitely there. What about the proximal LED? That's the question.
Do you know how to, okay, move it from distal to proximal slowly. Yeah, come. No, don't go that fast. You're in the guide. Go distal. Yeah. Go. Keep coming. Now move the cursor. Yeah. Slow. Right there.
So,
No,
so
little
the
bit more.
ostium does not have.
Yeah, keep coming.
Ostium does not have ring calcium.
No,
Kidney,
go
but
distal.
Below
Yeah,
the ostium,
right there.
there is a ring
Yeah.
calcium.
Yes.
Can you
In
come
the
a little
proximal
bit?
LED,
That's
there is
it.
a ring calcium.
Come back, distal. More. Keep coming slowly. So this is a LED itself, but the lumen is large.
Yeah.
Even though there is a 360-degree calcium. You see that? I mean, based on your, it is almost 9,
Get a fielder wire
right?
and get this ready.
So
Clean
just
it.
at the ostium, you don't see a lot. Go back to the
Clean.
ostium, little bit. No, you're going distally, proximal. Yeah, right there. Stay. Yeah, right.
It's
Yeah.
got a nodule kind of
Yeah.
thing.
I don't think we need anything. If you want, we
don't
can
need
cut it.
anything.
Yeah.
Yeah,
Okay,
we
cut.
we
Just a
can
normal
cut it.
cutting or
Yeah,
cut.
But
no need
let's
IVL.
decide about the circ now or later.
So I'll remove the rota
Yeah.
wire. Now
But-
you want IVUS the
I was
circ,
of the
right?
circ after doing the cutting balloon here.
No, let's wire image. Oh, you
Yeah.
want to cut first? Okay.
Yeah.
So we can
Can
go.
you show the IVS little
1,
proximally?
2, 3,
Little
4.
proximal.
Proximal means you're going
No,
to
you
the.
should have the headphone. He didn't. Why didn't he have headphone? None of the fellows have headphone.
Because you
Huh?
started like.
Okay.
Give the phones to the fellows. Come.
Yeah.
Give Kiss headphone to.
3.56. 6.
Can
And
you
let's put
come
a wire
here?
in the circ.
You do the things.
Yeah. Wire in the circ.
Give the headphones to the fellows.
Okay, so what we'll do is first we are going to do a cutting balloon and then we do the wire. No, put the wire in the circ now. Here.
Oh.
And you are right. That Himanshu, if we can have no touch in this case circumflex, will be happy. I'm the usual guy who try to modify the side branch and go through that and kissing. But this case, minimal will be fine.
Maybe sir, they can just replay the full IVUS. Just
Okay.
because it was very fast run, no, the new IVUS.
Yeah.
Did you do 8 millimeter, 4 millimeter?
4.
Yeah,
4.
it's 4 millimeter.
Let him play 1 second. Let's put a wire and then
We have
while.
fixed at
Yeah.
4.
So this segment of the LED has ring calcium, and
Yeah.
the lumen is almost 4 millimeter square, so small lumen.
Stop there. Yeah.
If you go to the proximal LED, just scroll it down towards the left side. Yeah, here you see the calcium is not fully cracked and the lumen is around 4 millimeters square. Vessel is almost more than 4.
Yeah.
But the calcium looks thin because when we can see the vessel behind the calcific plate also, so probably the balloon will crack it. This part of
Superficial
it.
calcium.
Yeah, and looks thin, ma'am, because we can see the vessel behind.
Go to another view.
I just had to make better curve.
Look at the curve. Very good.
Curve is lost. Yeah. So we have 3.5 cutting balloon ready. Let's wire the circ so that if some plaque shift happens, we can just take care of it. And then we'll show the IVUS of the ostial circ. We want to go beyond multiple disease. There is a OM and so, but our goal will be just make sure that ostium is not too bad. It is bad, but not too bad. Lumen as long as 3.5 and so will be okay. This goes to the OM all the time. Yeah, good. But we'll do it only IVUS after the cutting balloon of the ostial LED because that's where the purpose is. That whether so much plaque shift happens or not. Yeah, good. We leave it there with a 3.5 cutting balloon, and that was decided because there is a thin layer. I mean, although circular.
Actually, I would have done 375.
Huh?
The vessel is almost 4 over.
Yeah. No cutting balloon. Yeah. So you mean question was, could we have used 3.75 versus 3.5? So this is the 3.5 Wolverine, and we'll try to do a few cuts back and forth.
Because the lumen at the tightest point is only 2.5, so even
Yeah.
a 3.5 should
Will
be
be
enough
good.
to
Yeah.
create cracks.
That's right.
At
Yes.
This, point.
There will be a disease. I mean, there is no question about there will be a disease, but question as long as not much calcium. Good. Okay, going up. 12.
Looks
And-
small. Okay, down.
And we'll pull back and go back again.
No, listen, you have to go inside here also. That's because you have to decide the length.
Yeah, yep.
Okay, good. That is where. Okay, down.
Just proximal to the septal, probably there is the lesion
good.
in the cranial
Yep.
projection.
Yeah,
Go up here.
good.
Okay. Get the IVUS.
You want to take a picture now? Yeah, I mean, ostial circ will look not pristine, but that's okay. Good. Let's take it out. Huh?
I'm thinking that you want to do some more there.
Where?
We didn't go
So,
over
Yeah,
that.
as
okay,
Dr.
go.
Himanshu told,
Yeah.
just proximal to the.
That's where we are going now.
septal,
Yep.
Yeah.
Here.
Right
Yep.
here. Okay, go.
And this is where probably there was the ring calcium on the
Yeah.
IVUS.
That's correct.
Okay. Now we are going to use our EYE bus. Use your eyes.
The best IVUS, ma'am.
Yes.
Yeah, yeah. Yeah.
Okay, we're going back there.
Yeah, we need you with a long 3.5
Down.
38. Another 3.5 38.
I actually could. put
Okay, let's do the
four.
IVUS.
No, we do the IVUS of the circ, right?
Circ. IVUS of the circ. Now, let me ask you from our panel, all the expert imaging guys or girls who are there, that what will be your cutoff of the lumen area MLA for circ not to do anything? We know it will be down. Question is what we will be happy.
If it is more than 4 millimeters.
Oh no, it will be less than that, my friend. I'm talking about can you settle for 2.5 or 3.0? That's the question. Ideally, you're right. Ideally, you are right. It's a 4 is the cutoff. But this is not the 4. We know it will be way less than 4. Question is, can we settle for 3.0 if there's not much calcium, and 3.0, can we settle for that? That's the question here.
Because data,
Where
Dr.
is-
Sharma,
yeah.
is for physiological jailing. So
Yeah,
if the
yeah.
lumen area is less than 4 millimeters square,
Yeah.
the circ can have physiological jailing. It's a
Yeah,
dominant circ.
good, good. Went in.
But maybe here the
Yeah.
lumen will be
Yeah,
bigger
good.
than that.
Okay, go. Okay, now
No,
go
but,
4 millimeter, change to 4 millimeter.
Or 2.
No, 2 millimeters too
Slow
slow.
speed better, please.
if the
Two.
area is
No,
less
no,
than 4
change it
also,
to-
Himanshu.
Yeah, 2.
Himanshu,
4
if
is
the
good.
area is less than 4,
Yeah.
the plaque burden is less, we can still accept it. The problem is
But
the
if the
plaque
plaque
burden
burden
here.
is more than 50% and the
Yes.
area is less than 4,
Okay,
then
good. Now you start live. Yeah, have this flush.
Okay, make it on the main screen. Yeah, good.
Oh, no, significant.
Still do it too fast.
Okay, good. Down, stop.
What is going on, guys? Make it 1. But anyway, you can see it now.
That's the way we image.
Ah,
Please,
yeah, yeah.
that's the way we've been imaging.
Do the manual
Yeah,
imaging.
no.
Manual,
Yeah, it's
0.1 millimeter
Yeah.
per second. I'm going to do it. Manual.
That's why many people like the Philips, because it's all manual. Okay, right there at the ostium, you come down a little bit, it is significant, lot of
Yeah.
plaque. But angiographically looks okay
No.
with all this. Huh?
No,
You
let's
want
do a
to still
cutting
put the
balloon.
stent?
No, let's do a cutting balloon before stenting.
No,
I
no,
think
you're in the wrong area. Why are you? Man.
he does not know anything. Please. You want to check it? You want to go there? Go. I'll take care of it. Go. Just show them everybody the ostial. So that's the decision making.
No, there is plaque.
Yeah.
Okay, let it run
That
again.
block, I think
Yeah,
the area will
significant
be more
is
than
that?
3.7. We can
No, no,
leave
no,
it.
no, no, no.
No, 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 my friend. Here. 2.49.
Full back. Okay, now go
I
slowly.
know what they're doing.
Stop, stop.
Huh.
Pull back again a little bit.
It is severe, yeah.
Severe.
Back,
Severe.
back.
3O cutting balloon.
Yeah.
One second.
Yeah, it's tight.
Do a 3O. 3O cutting balloon.
Hold
What
on.
do you think?
Yeah, 3O cutting.
Yeah. Okay. 3O. Okay. Stent length. Let's tell the stent length now.
Please.
Yeah, our main I was guy is gone, so everybody's expert now here.
I know.
Not expert. They don't how to handle them.
based on the original IVUS, you will leave it, no ma'am, this
Huh?
circumflex ostium.
Would you?
If we did not do this modern IVUS, if it was just the old eye-based IVUS, you will
Oh,
leave
yeah.
No,
What do you
no,
mean, sir?
no.
No, you're saying EYE.
No, but I would say no. I would still say our EY, right even from the beginning, anytime there's ostial tight lesion in every view. Here.
Okay, hold on. Let's go to the original.
Yeah.
Let's go to our legacy. Not here. Okay, good.
Yeah.
Okay.
Here. Look at that. There's very significant ostial lesion. So I would say that our I would have done the cutting balloon with the 2.75 or 3O without imaging. If you're asking the question, yes, go. And we are just end up. I would say that I was just confirmed it because very significant. Now, only question was that do you need to go a little more aggressive approach in terms of the IVL and so, but no, because there's not much calcium, does not need the rotablation. I think it will be good enough to do it now. A lot of people say, well, maybe after this, you can just do a drug-coated balloon in this large vessel. There's a lot of discussion happening at present, particularly from Europe, because the initial bifurcation trial has been very positive, but there are very few left main, but now people are trying to do even drug-coated balloon for the large circumflex and just cross over. So whether it's a right or wrong approach is not supported by any data yet. But this is the concept moving forward, and I think particularly the person who is high bleeding risk, I'm completely fine to get a suboptimal result, but without dissection.
Okay.
But you have to have no dissection because that's the one dissection will create a trouble in the further on. Go one more, little distal part of the.
You said
Go
no
go
need
one
for
more.
dissection,
I know, but
suboptimal.
no, but yeah, just no pull back. Actually, right? Yeah, good. Here, yeah, just low pressure. I'm not going to very high pressures here. Yeah, and just wait for a few seconds. So clearly we know little longer inflation, 30 seconds, and so compared to quick up and down 5 seconds gives you better results.
How much pressures did you use, Dr. Sharma, on
Yeah,
the
this one, LED I use 18 with a 3.5, and this one I use 12 only. You want to take a picture now?
Cutting balloon looks too small for the
I
vessel
know.
size,
Yeah.
so go.
Good.
Okay, good.
Now it's okay. That's what
Now
we wanted.
we'll do stent.
Yeah.
Do you want to put a 4-0?
No, 3.5. 3.5, 38, right?
The left main,
Yeah.
just by with the eyes, is at least 5 millimeters.
No,
so-
we know, but that's okay. You want to put a two separate stents? We can
No,
do.
one
Good.
stent,
3.5, 38. Yeah.
We put one stent.
Yeah, it's not a 4.0. 3.5, 38, and then we can do proximal. Okay. Let's go there now. And we are not going to use the European approach that if the side branch looks good in the EBC1, that they dilated every case with the kissing. Here, if looks good, circ looks good, we leave it. Because our Excel data did show that if your single stent approach, your routine dilatation was not helpful, rather has a trend towards higher stent thrombosis at 4 years. Now, initial we can get 4.5 balloon. You had a 4.5, 12?
8.
8?
For
Okay.
the left main.
Okay. Good.
Is it Zions?
Yes.
This is the Zions, little die. Other one could have been a Synergy Megatron. Good.
Yeah, good.
Yeah.
Okay.
Will it go to 5 or 5.5?
I think this.
This looks 5.5.
Yeah. So we.
No, that's why I wanted 4, but he was insisting, no. 4 low pressure, and then proximally we could have gone. But
You had a
anyway,
4.5. Yeah. 1 second, one more. Yeah.
with the Zions, the 3.5 and 4 is the same platform. No,
Yeah,
Dr.
same
Sharma?
platform,
The
exactly.
Zions-
Yeah. No, but remember the balloon, the question is the platform same, but the balloon is different.
no, we understand. But
yeah,
what we are saying
yeah,
is when we are post dilating, will it?
Yeah,
Okay. Give us.
good.
You want a picture or leave it alone?
No,
Let's
leave it as
just,
proximally dilate, and then we take the picture, and then we do IVUS, and hopefully we are reaching to our time. Full 1 hour, so no lecture. We just, there's a very interesting case of the
I
super
was
chip.
ready.
Yeah. And super chip case, and super chip is combining, about 7 years ago, when we had live relay to ACC, we did the same thing. Balloon valvuloplasty and PCI, the left main bifurcation. Then one time in the CRT, we did same. Balloon valvuloplasty and PCI. We can take the, yeah.
IVUS is ready just to check the final optimization, okay, in the left main.
Dr. Kinney, what is your practice? Before pot, you remove the side branch wire
Yes,
or you
yes.
still keep it?
No, remove it before.
Yeah,
You
remove.
it,
Yeah.
And then
EBC
rewire.
says the other way actually.
I know. EBC says now you recross and do a kissing. Every case. In EBC, every case had a kissing, and that's why they call it a stepwise provisional. And although
No,
23% requires second stent. Yeah.
Rare situation, remember you can have your wire just stuck behind the stent. So always remove it and then recross.
Recross. That's what I would do.
And I think again,
Good.
we are telling you this recrossing of proximal cell, distal cell does not work. Just
Optimal cell.
recross to optimal cell. If you recross, itself is good. Ready?
Yeah.
Okay.
Perfect.
Yeah.
Very good.
But,
Very good. We need a little vasodilator, but do the imaging first.
Okay. Only issue is look at the distal LED.
No, this is.
Vital LED has
Yeah.
no flow because
It will have it. No. Yeah. We haven't given the vasodilators, but let's see the proximal one. All the flow will come back there. If necessary, we can do a touch up with the balloon, but I don't think will be needed. But most important, we want to make sure the proximal, your left main is good. Or
Okay,
actually,
go to
LED.
1 millimeter, okay? Good. And we'll just do the left main.
Yeah.
Distal, we have to see the distal edge, proximal edge.
So how often do you encounter the stent elongation in your practice, Dr. Kinney and Sharma?
No, you mean LSD.
Longitudinal stent elongation, not the deformation. 3.5 stent, we have dilated pot.
Oh.
We have,
One.
if it is in the ostium, it will hang in the ascending aorta, right?
Yeah.
3.5 dilating with the 4.5 will increase the diameter by 2 millimeter, it seems. Himanshu is also there who has published the modified pot.
But in this particular case, the stent in the left main is a very small segment, so there will be no elongation because they were very careful to do the
Yeah,
pot covering the whole segment of the left main with the first dilatation.
yeah.
But if it is very long stent in the left main, we come from the carina back, the stent keeps on elongating the while it is dilating diametrically. But in this case, probably it will not
Good.
be there. But of course,
Okay, distal edge, let's see. Okay, good. Go 1 millimeter, start recording.
Go to the main
Okay,
screen.
good. It's nice. Well opposed. Oh, here we may have to go. Good,
well
good, good.
expanded also.
Yeah. Keep coming back.
Yeah, fully expanded.
And circosteum is
Now
coming.
you see how slow it is, SS?
Yeah.
Oh. 1 millimeter is too slow.
For this one is Sharma's speed. That's all
Yeah.
right. I was, yeah. Angiogram, you can do any speed. I
Okay,
was
so
good.
everything is nicely opposed. Left main is very
Yes.
good.
And well
Look at the
expanded
left.
also,
Yes.
fully
Yeah.
expanded.
And this is,
Left main also
No,
well
this is
opposed.
left main.
Yep.
Yes.
Yes.
Are you
well
coming
opposed,
back
yeah.
slowly?
Yeah.
What's going
coming,
on?
coming, coming.
Yeah.
Coming to the guide soon.
Okay, good.
Beautiful.
So
Yeah.
just at the ostium, stops just close to the ostium.
Beautiful. All right.
Not
So-
hanging in the aorta. So now let us give, you want vasodilator? Yes,
Yeah, yeah.
AS.
Yeah. No.
Okay,
so
give a
Vera-
little bit of
We didn't
verapamil.
post-dilate the distal portion of the stent. Am I right?
No, we did not, but go to the distal edge of the stent and go get a quick MSA. Yeah, right there.
MSA is
A
that
little
good?
bit inside.
MSA is
Yes, it's good.
MSA is around 7.5
Yeah.
there.
Yeah.
More
I'll leave it.
Circumferential calcium.
No, there is one spot, I agree, with a little bit inside 7.9.
Get a
now
foro
keep
balloon.
coming back,
If you want,
coming inside
get
the
a foro
stent.
balloon.
At some spot,
Foro
there is a
12.
little where you...
Yeah.
Okay, there,
This one, yeah.
there. Yeah, 5.1.
5. So there we can do 4. Let's do it.
No,
Epicranial.
3.5.
3-5. Okay.
3.5.
Yeah,
3.5.
3.5.
You have the 3.5 high pressure balloon? 15.
We have it. No, we had the cutting balloon. Oh, we had it before. Okay. Yeah. All right. Hemodynamic patient tolerating. This area is the one which you can do now on the stent boost. That which need to.
We never
Area
took
not-
a cranial picture. This could be that. Okay.
Yeah, here.
Okay, take a picture.
Okay. Yeah. We'll do 1 second. Guys,
No,
stent
no
boost.
need for stand boost. Come.
Stent boost. 1 second. We'll try to show. Good. Okay. The pace, 1 second, we have to close. Good. Pacemaker, we can remove the pacemaker, creating a,
It's
Huh?
dependent.
okay. You will not be able to see the boost.
I don't know why you need the boost. It's too
Yeah.
much of radiation.
Enhancement failed. No, not the current booster,
No,
not here.
It's still more radiation.
Yeah,
Okay, hold it.
okay. Yeah, we needed a balloon also. So, okay, so which area we are going to dilate now?
I'll tell you where. But
The
we're
mid
not going to
part of the
repeat the
stent.
IVAS.
Yeah. Good, go.
Okay, go here. Yeah, you could see that. That is where the ring of calcium was.
18.
At the left, just inside the septal. Down.
Cut down the pacemaker rate to 40.
Okay.
Yeah.
Go up here. You can go. Now we are good. Okay.
See, the pressure comes up when pacemaker goes down. Pace rhythm. Atrial kick. There's no atrial kick anyway in this case, but somehow it's a dependent on that. Patient is okay? Good. Done?
Yeah.
Now we have to take a wire out and give vasodilator. We give a little nitride. All the pressure is on the.
We have nitride.
Yeah. Because avoid the nitro in this situation. And nitride may decrease the pressure, then you have to push a little more. Yeah. Okay, good. All right. Great flow.
Great results.
Fantastic. And see, apex, it was all vasodilator issue. Don't do any more picture. Yeah. All right. Anything else? We are done for our presentation right on the dot. We started at 7:02, finished exactly at 8. Good. And the pacemaker is not needed.
Yeah.
So
Oh,
when
no,
you
no,
plan to
no,
do
no,
a
no.
Yeah.
TAVI.
Let's see. Let's see.
Tavi after 1 month. We wait for 1 month.
Yeah. Again, a balloon expandable valve.
Yeah. In this case, yes.
Yep.
All
Thank
right.
you so much, sir and ma'am,
Thank
for
you, Dr.
sharing a
Sharma, sir, and
wonderful
Dr.
case
Kinney, ma'am.
and
Thank
working
you,
on a
everyone.
Saturday.
Please.
Thank you so
Beautiful.
much and have a good rest on the weekend. Thank you so much.
Thank you. Sorry. Off.